Awesome. We are going to record today. So we're going to talk a little bit about treating complex trauma today and helping youth navigate complex trauma symptoms. We're going to heavily focus on TF-CBT interventions today as well, although you will see if any of you are DBT trained or have familiar with DBT skills, we're going to kind of talk about how to weave those into TF-CBT for complex trauma as well. My hope is I have you all for 2 hours. So I think we'll go probably for about an hour and then just do a short stretch break if you need it. Um, I think that I have plenty of content for you all today, but I also want this space to be most helpful for you. So if you want to talk about cases or if you have questions throughout the presentation, please, you don't have to wait until the end of the presentation to ask questions. Probably best when I'm sharing my screen, I lose some of you all. So just use the raise hand function and then you'll pop right up to the top. And lovely to see clinicians and program managers and directors here. Okay, I'm going to share my screen here as well. Get these presented for you. Okay, I'm going to explain a little bit about this tree theme that I have going on. So we're going to talk a little bit about trees and forests as we talk about helping youth navigate complex trauma symptoms as well. So stay tuned for the rationale of why you're going to be seeing so many trees and forests. Okay, a little bit about me. So I'm Dr. Brandi Liles. I'm a psychologist by trade. I'm also a daughter, a sister. I actually have a twin sister and a partner, and we're living the no dogs, no kids life. So we love to travel when we can. I'm a huge college football fan. I was just telling Sadie, I'm originally from Oklahoma, and in Oklahoma, you're basically indoctrinated to be college football fans very early on in life. Um, I'm a new business owner, so Red Leaf Psychology is just a couple years old. It's a little toddler, and my colleague and I, Dr. Hawk, really just saw a need both in training and consultation of areas of our expertise, as well as clinical work for people who maybe need additional services that their insurance doesn't cover. We also work at a community mental health center for clients who qualify for Medi-Cal as well. And so that is our primary job. And so I'm doing a lot of TF-CBT in both the community mental health world and in the private practice world. I'm a nationally certified TF-CBT trainer. And so I do a lot of introductory TF-CBT trainings, but do a little bit less of these advanced trainings, which I really appreciate. So I'm glad that you all wanted some of this more advanced training. And I have many, many years of experience working with kids and youth and young adults and their families, both in TF-CBT and DBT, and also newly trained in ACT as well. And you'll see some ACT flavor in this presentation too. Okay, so why are we here? I want to review just the complex trauma symptomology with you all and cover some conceptualization, kind of some of the dysregulation to look for. This is not going to be surprising for you all who have been treating complex trauma. They're going to sound like your clients. They're going to look like your clients. We're going to talk about why some of the barriers to getting effective trauma treatment for complex trauma exist and sort of how to sort of navigate some of those barriers. And then really my goal is just to increase both your knowledge and your skills in providing trauma responsive interventions for these kiddos. And then hopefully we'll have time to do some case consultation, or I'm happy to share some of my case examples as well. And Sadie, you'll monitor the chat in case there's any questions. Just please feel free to interrupt me.
Yeah, of course.
Okay, so my first tree analogy is to think about the difference between acute trauma and complex trauma. Okay, so this tree here is our acute trauma tree. And you can see that it's clearly affected by its environment. And so these might be our kids that are exposed to either type 1, right, those natural disasters, car accidents, medical traumas, or type 2 traumas of interpersonal trauma, child abuse, neglect, sexual abuse, physical abuse, those type of things, emotional abuse. as well. Sometimes this can be brief in nature, oftentimes because of avoidance, right? And the lack of early intervention, these symptoms do go on, but there is sort of this temporary disruption in functioning. So diagnostically, these are kids that meet adjustment disorder or PTSD, or maybe they don't even qualify for full PTSD, but they have some trauma-related symptoms. And typically we'll give like an unspecified trauma disorder. Usually with our acute trauma kids, not always, but usually there's some existing protective factors as well. So there was either pre-trauma functioning that was at a higher level, there's more caregiver support, and some protective factors in the family as well. But again, this tree is clearly affected. These trees need intervention as well. But today we're here to talk about these kids, right? Little rougher around the edges, right? You can see that they've had to survive long-standing survival of, but this tree is alive. You can maybe see right up at the beginning, right? You get see a little bit of moss there, right? Long roots in this tree. But it's weathered. It's weathered. And so our complex trauma kiddos, they usually have a mixture of both type 1 and type 2 traumatic events. Oftentimes the type 2, the interpersonal traumas are chronic. They're long lasting. They've maybe gone on for years and years and years with some disruption in early attachment figures. And honestly, diagnostically, these kids look like a lot of comorbidities, right? So you might see PTSD, but you might see bipolar, and you might see borderline personality disorder, and you may see, even some perceptual disturbances, psychotic disorders. Really, our conceptualization of complex trauma is PTSD plus dysregulation. And you'll often see the impact across various domains. So impact on their physiology, emotions, impact on their relationships, right? Their social, their emotional functioning, and some of their identity functioning as well. You all are seeing these kids, yes? Yeah, yeah. I'm seeing some nods. I'm seeing some nods. Okay, so I thought it might be helpful to go through the 5 primary areas of dysregulation, and this can be very helpful for your assessment of complex trauma. I often ask about these 5 areas of dysregulation to sort of see where the dysregulation lies. Now, again, often these kids are going to also have PTSD, and then we're kind of looking for that plus. So let's start with emotional dysregulation, right? And so these kids often comes with high sensitivity, high reactivity, and a slower return to baseline. And some of that high sensitivity, it's really hard to tell for these kids whether that's just genetically, they're more highly sensitive to emotions, right? Emotions are easily triggered, they are experienced more intensely. Marsha Linehan from DBT actually calls people who have emotional dysregulation like emotional burn victims. So if you think about burn victims and having wounds on the outside of their body, and when they're touched, it's very intense. It's a very intense pain that can lead to suffering. And that's how our kids are emotionally, right? They're highly sensitive. Their emotions and the intensity of their emotions are easily triggered. They also have high reactivity. So when those emotions, that sensitivity rises, right, they can react quickly and impulsively when emotions arise. And again, some of this is genetics, some of this is their chronic traumatizing environment that they've had to learn to sort of quickly rely on their survival skills, which is impulsive, right? Our survival skills are impulsive in a helpful way, and then that impulsivity then gets transferred over in maybe some ineffective ways. We also see a lot of, not on the slide, right, is like slow return to baseline. So sometimes they're highly sensitive, then they're reactive, and then it takes a long time for them to kind of settle back down into baseline. And also their baseline might just be higher too. So they may be just higher intense emotion. They might have higher intense emotionality just when they're at their regular baseline. And then it peaks even higher when they're triggered. You may also see a lot of emotional instability in these kids, right? So like emotions can move from numb to flooded. Sometimes these kids have problems with anger as well. Um, Oftentimes these kids, because they're sort of like moving from extremes, so like numb to flooded is one of them, right? Sometimes they're overly alert, hyper focused, and sometimes they're totally dissociated. And oftentimes they're living their lives on these parts of the spectrum. And that can feel manipulative, right? So like oftentimes they're labeled as this kid is manipulating me. They're like it's as if they're like intentionally, purposely moving from these extremes. And I just haven't found that clinically, right? I think that they are actually moving from extreme to extreme, sometimes moment from moment, because of both their biology, their high sensitivity, and also just their chronically invalidating environment. The other kids that we don't think about as much related to emotional dysregulation is the over-controlled kids, right? So these are excessive levels of self-control, perfectionism, achievement, because of sort of just how our society functions. We don't often see these kids as dysregulated kids. We usually only think about the underregulated kids, right? The kids who are having anger outbursts, who are beating people up on a whim, right? Who are self-harming and having a lot of behavioral dysregulation. But on the other side of that dysregulated spectrum is our over-controlled kids. And if you think about, some of these kids have popped up in the news where oh, this was a track star who made straight A's and then died by suicide. And nobody recognized how much this kid was suffering internally. And that's usually an example of these sort of over-controlled emotions. And so sometimes complex trauma doesn't look like the under-regulated dysregulation. Sometimes it looks like the over-controlled emotions. These are the kids who've been through hell and back and are like, oh, I'm just still going to school and, like I'm making good grades and I'm taking care of my siblings and I'm doing what I need to do. But internally, there's a lot of extreme distress that they're trying to manage alone. And sometimes these over-controlled kids don't get into our office, right? Because teachers aren't referring them, parents aren't referring them, resource families aren't referring them. But it's really important for us as clinicians, if they do come into our office, to be able to look at this as also emotional dysregulation. It's just more socially accepted emotional dysregulation. Any questions about emotional dysregulation? All of this sounding very familiar to you all? Okay, yes. All right, let's talk a little bit about behavioral dysregulation, right? So these are the things that we see. These are often what our kids get referred for, right? So impulsive behaviors, acting quickly without examining consequences of behaviors, suicidality, right? So this can include ideations, intent, plans, or behaviors and attempts. We're going to talk a lot today about tension reduction behaviors, right? So like when you experience internal distress, what are the things you're trying to do to push that distress down? And from my clinical experience, this will look like substance abuse, non-suicidal, self-injurious behavior, sometimes even like problematic relationships, sometimes problematic sexual behaviors, right? Coercive control, anything that a kid can do to avoid that internal discomfort. And with our complex trauma kids, because they've had to survive their invalidating environment for so long, they often have tried a lot of these tension reducing behaviors, which can obviously cause a lot of life functioning issues as well. And then sometimes we see the behavioral dysregulation in anger outbursts, right? Yelling, screaming, temper tantrums, aggressive behavior. These are when kids are storming out of our office and we're like, oh, what just happened? So we can see some of this behavioral dysregulation in their lives, and then sometimes in our clinic as well. All right, let's talk about cognitive dysregulation, right? And so some of the cognitive dysregulation is just total dissociation, checking out cognitively, disconnecting for various periods of time. Oftentimes this sounds like I'm seeing myself outside of my body. This is where it can get a little confusing diagnostically if there's actual perceptual disturbances or if it's more sort of cognitive dysregulation from trauma, and sometimes it's both. You can also see cognitive rigidity, right? So not a lot of flexibility or fluidity in their thinking. It can be black or white, it can be extreme. They can have difficulty changing their opinion about things and specifically about people, right? So sometimes if this client feels wronged, it's really hard for them to come back from that perceived rejection or that feeling of being rejected. Also sometimes hard to distinguish from some of your psychotic disorder too is like there's a lot of paranoia and distrust. I'm just realizing this is actually about trees, and I don't mean it to be exactly about trees, right? But like, so the paranoia is worrying about people out to get them, which again, from a survival perspective, like totally makes sense, right? They have had to worry about people out that were out to get them. And then difficulty sustaining attention can also be a cognitive dysregulation. So attentional efforts that move again from that hypervigilance to that disconnection or inattentiveness really, really quickly. A lot of these kids are diagnosed with ADHD. I would say some of them have ADHD, but as you all know, ADHD can sometimes be a very trendy diagnosis without looking for the underlying trauma that may have existed for these kids. All right, some of the self-dysregulation. This is where you might get kids, again, who sometimes get a BPD diagnosis. I'm often asked, is BPD the same thing as complex trauma? And my answer is usually like, usually yes. Yeah, yeah, exactly. It's just, like, kind of. I would say the majority of clients that have come across my clinic who meet criteria for BPD also have complex trauma. I do think there's probably some people out there who've experienced their environment as significantly invalidating without that trauma exposure to abuse and neglect and things like that. But I would definitely say that's more rare. The more common form is both complex trauma and BPD. And I conceptualize those things very, very similar. But this is where you're going to see some self-dysregulation, right? Unstable sense of self, sort of this constant state of changing identities. Sometimes I call this the chameleon personality. So it's like whatever group they're in, they're trying to sort of fit into that group. And so they can change sometimes their appearance, sometimes how they identify, sometimes how they dress, right? And they're kind of trying to mesh in with different groups, but don't really have a clear sense of their own values or their own sense of identity. This is also described by a lot of my clients as sort of a chronic sense of emptiness, which is also one of the criteria of BPD too. They often feel lonely and disconnected, and even as they're building, more relational resources and they're having more relational support, still internally, it can feel very lonely and empty for them. I've been reading a lot recently about self-hate, and like just how early on self-hate can be cultivated in kids, and especially kids who've experienced complex trauma. One of the podcasts I was listening to, I'm gonna forget his name. The book's not right in front of me. I'll find it on break and chat it to you all. But he talks about self-hate almost as like learning a language. So it often happens so early. It's as if you're learning a language. So if you learned English, right, you don't really remember learning English. You just learned it, right? You learned it from your environment, and that self-hate is often like a similar concept where it's like you don't really remember where it came from, but you also weren't born hating yourself. And so you've learned it along the way from your environment, from your teachers. And some of these teachers can be really ineffective, especially if they're abusive and coercive to these kids. And so this leads to sort of a sense of inadequacy and excessive guilt and shame, a lot of unjustified shame, just feeling shame about who they are as a person, unworthy of love and success and connection and all of the things that we need as a human being to be able to survive long term. And so this self-dysregulation often comes for a high need for external validation, right? And so they evaluate their self based on what others can provide for them. And this can be a tricky thing too, right? Because we're always going to experience some invalidation in our relationships. And when that invalidation happens for these kids, again, think emotional burn victims, it can really cause a lot of pain and discomfort, and they're searching for themselves in other people's validation, which you can see how that causes some functioning problems as well. Okay, and then the last category of dysregulation is interpersonal dysregulation. So this is dysregulation in their relationships. Oftentimes, these kids or young adults come with unstable or chaotic relationships, sometimes in their primary caregiving relationships, but also in relationships that they choose, peer relationships, romantic relationships. Sometimes they can be abusive and coercive and kind of like hot or cold connections. I'm certain that you all have probably felt some of that in therapy too, where it's like, oh, we just had like a really amazing session. I feel really connected to this client. And then the next session, it's like they're giving you the cold shoulder and you're not really sure what you did to get them to sort of switch over. And so that's how some of the interpersonal dysregulation shows up. Some fear of abandonment, right? So extreme worries about people leaving them. And oftentimes this results in the behavior of leave before you are left. And so again, these kids sometimes drop out of treatment once they start feeling connected. The connection, the therapeutic connection itself can be a trigger for the kids' trauma-related symptoms and their dysregulation. They are sometimes minor invalidations, again, are experienced really intensely in their relationships. And then oftentimes they'll have maladaptive connection seeking behaviors. So sometimes that looks like constant reassurance seeking, and other ways it's extreme methods to attempt to connect. So even thinking about suicidality, sometimes the function of suicidality or self-harm are maladaptive connection seeking behaviors. Now, again, these kids are often labeled as attention seekers or manipulative, but I really want to like normalize that connection seeking is a common human need, right? Like going back to Maslow's hierarchy of needs, which he really what based on the Blackfoot tribe and some of their indigenous philosophies, right? But like that safety, that connection, right? That relationship building is the third rung on the basic needs hierarchy. And so I just want to normalize connection seeking behaviors. What we want to adjust is moving it from a maladaptive connection seeking behavior to a more adaptive connection seeking behavior. Okay, I'm just going to stop sharing for a minute so I can see you all. Any questions so far? Any cases that are coming to mind? What are some of your thoughts, reactions, reflections so far? And anyone can just unmute and pop in. Michael. Oh,
Oh, I did
you're
unmute on
unmuted.
purpose.
So
And I'm not a therapist, so except for yeah, I have a son we raised through foster care, so a lot does look familiar.
yeah, yeah, yeah. A lot of these kids have that disruption, that primary attachment early on.
Yeah, I just really like the way the slides are laid out and what you have to share in terms of how it's presented. It's really relevant to the community that we serve.
Good. I'm so glad. I wish there was a more effective dysregulation measure. I'm going to talk about the DERS a little bit later, which kind of gets at some of these points. But oftentimes I'll be integrating these things into my clinical interview when I'm interviewing someone who has a chronic trauma history, right? And it's kind of given that flavor of complex trauma. I'll kind of write out these areas of dysregulation and sort of ask them, what is it like for you emotionally? What is it like for you cognitively? What is it like for you related to your identity? And oftentimes they'll give you the information that you need related to their dysregulation, where that sort of like pain point is in these areas.
I'm going to be particularly interested in how you approach a client who is triggered by that therapeutic relationship, because I think we see a lot of kids who, and parents as well, who leave before,
Yeah.
just as the therapeutic alliance may be
Yeah.
there and you're beginning to do the work, and then the attendance gets spotty. And sometimes there are chaotic things going on in the life and the family.
Sure. And sometimes
But
therapy
it
isn't a
also,
priority, but other times it's like,
Mhm.
oh,
Yeah,
it seems like the relationship is what triggered the avoidance. Yeah, I mean,
yeah.
just jumping in just a little bit, we'll talk more about engagement, is I'm doing a lot of anticipatory guidance around that the very first time I meet a kid. That again, it's giving me sort of either has the history of complex trauma or is giving me the flavor, right? Those flags, those complex trauma flags are going up for me. I'm going to be talking a lot about this space may feel uncomfortable. This space might feel transactional, right? For a lot of, I work with a lot of kids who've experienced sexual exploitation and trafficking, and oftentimes they experience the therapeutic relational as transactional. You're doing this so you can get this, right? And even if that's not a sexual need, I mean, and our systems are kind of set up that way, right? Oh, you don't show 2 times, and then I'm going to have to send a letter and discharge you and all of those things. It is a bit transactional. And so, recognizing and being transparent about some of that transactionality, but also that I care about you as a human being, regardless of whether you end up doing therapy with me or not. And I'm wishing, I want functioning for you. I want well wishes for you. And I'm also not going to row this boat alone. So I use the analogy of the rowboat quite a bit, where it's like, hey, you're out in this storm in this rowboat alone, and I'm willing to swim out in the storm and get in the boat with you and start rowing to shore, but I'm not going to row by myself. So you got to pick up some oars and start rowing. And some of that means showing up in an environment where you may feel triggered and where this connection might feel uncomfortable. And again, I'm doing that sort of really early on in treatment as an anticipatory guidance of it's not like if this is going to happen, it's probably when this is going to happen for complex trauma. Great questions and comments,
Okay.
Joelle.
Thank you.
Yeah. Okay, let's talk just a little bit more about conceptualization, then we'll jump into assessment here. You guys see this? Yes? Okay. Um, all right, so a couple other things, like most things we want to assess, not assume. Not everyone with chronic trauma exposure is going to have complex PTSD and dysregulation. And so we're really like assessing whether that's accurate or not. Oftentimes the kids with chronic trauma might just have PTSD, and you can kind of treat them more as your typical TF-CBT cases without some of these adaptations. And the other thing I really like this quote is the difference between dysregulation and defiance is motive. So defiance is I want something and I want something now versus I don't have the skills to handle this. And that's important because a lot of these kids can show up defiant and oppositional. I'm not saying that they don't have any defiance or oppositionality, but oftentimes we'll slap the externalizing label on them, especially things like ODD, which we know is sort of wrapped up into systemic racism and how we view Black and brown kids as more oppositional versus traumatized. And so just really being careful when we're thinking about defiance and dysregulation, and being intentional about some of our diagnoses as well. And it's not usually a won't, it's a can't yet. It's I can't handle this yet. I don't have the skills to manage this yet. I can't adaptively connect yet. And then that's part of our goal for treatment is to be able to give that knowledge and skills. Um, the other thing I want to say, and this is just validation for you all, that diagnoses may not be clean or clear, and that's okay. We're going to treat youth anyways, right? We're gonna do our best. We're gonna show up with the most intentional hypothesis we can for right now, and that might sort of change as we go through assessment. Okay, so besides PTSD, right, which obviously you're doing for all of your TF-CBT cases, we're using the CAPS, the Child Abuse Trauma Screen right now because it's free. But if you all pay for the UCLA, that's great. For adults 15 and older or 18 and older, that's going to be the PCL-5. But you also want to kind of take a look at some of these other categories when it's giving you a complex trauma feel, right? So looking at suicidality either through the Columbia or the CAMS assessment or the DBT LRAMP is a great one too. And not using all of these, right? But I just put a couple options on here to think about that. The dysregulation emotion scale is the DERS, and this gives some helpful information about like how intense and sensitive kids' emotional dysregulation can be. And there's also the life problems inventory, which looks at dysregulation a bit too. I don't use that one as much as I use the DERS. And then also getting a sense of self-harm. And so usually we use the inventory of self-harm assessment, the ISASS, to look at not just cutting, but burning, wound interference, other types of self-harm and the functions of the self-harm. So what I like about the ISASS is it looks at, are you self-harming for affect regulation? Are you self-harming for connection? Are you self-harming as an anti-suicide? I'm trying not to die, so I'm cutting instead. And you get a real clear picture of what some of the function of self-harm is. And sometimes kids don't even know the function of their self-harm, but when you start asking these questions and they give little subscale scores where you can say the highest subscale of your self-harm seems to be the function of affect reg or anti-suicide or feeling generation, right? Like, am I trying to generate a feeling through harming my body? You're probably going to need some extended assessment sessions versus your typical TF-CBT cases. And I would say has been so common in my clinical work that you find out about trauma sprinkled throughout all of treatment. And so oftentimes they don't disclose all the traumas in the first assessment sessions. And you might have your hypotheses, right? Where it's like, I don't know, it just seems like there might be some sexual abuse here that hasn't been disclosed. And sometimes it's not till months later until some of those other traumas come out. And sometimes there's gaps in history, right? And so when you're thinking about historically and trying to get a historical picture of your kid's life, sometimes there might be large gaps of years, and sometimes they don't remember due to, just like not having the knowledge, but sometimes it's the fear of disclosing and the fear of judgment and stigma that kind of keeps them from telling what has happened. And again, I think that's where we have to sit with some of our discomfort of we may not know it all. At the beginning, we may not have a clear conceptual picture, but we're going to move forward with what we do know and then be open to changing our hypotheses clinically as we learn more about our kids. So a couple of the EBTs for complex trauma, right, is you obviously have dialectical behavioral therapy to address suicidality and self-harm, and sometimes that's the first treatment approach. John Briere also has IT-CT, which I've had some training on early on, which is a trauma-based treatment for complex trauma. And then there's adaptations to TF-CBT, which is what we're going to talk about today. So why would you choose TF-CBT for complex trauma kiddos? Because they have high rates of trauma history and trauma symptoms, right? And oftentimes, because of their diagnostic confusion, right, because of their impacts of domains that have been affected by their functioning, they often don't get trauma treatment right away. Also because they're dropping out of therapy more often and have difficulty with some of this safety and stability. And, TF-CBT does prioritize safety and stability. And for most of these kids, we're going to talk about this, you're going to be moving the enhancing safety of your practice components up so that you can address safety and stability first in treatment before you move on to more of some of the more formal trauma processing. It's also effective for youth in multiple settings where our youth with complex trauma are, like foster care and the juvenile justice system and residential placements and school. And it also has adaptations for diversity, right? And there's been more work in this over the last 5 or 6 years, of thinking about How do we make adaptations to TF-CBT for cultural groups, for racial and ethnic groups, for neurodivergency, and other specialized populations like LGBTQIA plus youth or youth who've experienced trafficking? And I'm happy on the break too to put in some of the implementation manuals for some of these specialized populations if you haven't had that resource yet. Okay, so in your TF-CBT training, you probably remember this. One of the differences between TF-CBT for complex trauma and traditional TF-CBT is your prac skills are going to be longer. It's going to be a bigger portion of treatment. And often this is because you may be dealing with safety behaviors, with life-threatening behaviors, and you've maybe had to move enhancing safety up. But your goal is still to be able to get to trauma narration and processing with these kids, to be able to tell their story, to be able to remember the contextual details and the thoughts and feelings of their trauma history, because this is where a lot of the shame lies, right? And a lot of these kids have high shame and low shame tolerance. And so getting to trauma narration and processing, even though there's all of this sort of chaos going on, is still important to be able to manage, help them manage some of that shame and let go of some of the shame that is unjustified. And then you have your integration phase, right, which you'll still do with these kids in the in vivo exposure, conjoint sessions if applicable, and then going back to enhancing safety. And then remember through TF-CBT, your parenting skills, if you have a green light safe caregiver, are implemented throughout, and also you're doing those bursts of gradual exposure. So not waiting for trauma processing just to in the narrative, right, or in the T part of the practice, but you're doing bursts of exposure throughout. This says 16 to 25 sessions, but clinically, sometimes it's 30, sometimes it's 40, right? You may be seeing these kids more long term. I think you still want to hold the conceptualization, though, if you want them to get them through trauma treatment so then they can focus on more present-oriented things. Sometimes these kids feel very stuck in the past, and we want them to help them move through the past to get to more present-oriented problems and issues and things that we can help them manage as well. Okay, so we've kind of already started talking about that, this related to, rowing the boat together. So building relationship and co-regulation. A couple things to keep in mind, and this comes a lot from the DBT conceptualization and working with people with BPD that I found very helpful to apply to this population as well. And some of it's just radical genuineness, right? And so like we're showing up in the environment in a genuine, authentic way. We're staying true to our values. We're disclosing some of those values to our clients as well. Even though there's a power differential in the therapeutic relationship, obviously, right? You want there to be some equity as well. You want there to be some sharing and appropriate disclosures and being a human being. And oftentimes these kids see us as like, oh, you're just a therapist, you're being paid for this work, which is accurate, right? Probably wouldn't do my job if I wasn't paid, but just because of the capitalistic society we live in, not because of my own values, right? But being able to show up and be like, this is why this work is congruent with my values. This is my purpose. This is the why, and showing up for our clients with this radical genuineness too. But sometimes that means that we also have to say like, hey, I'm frustrated with your behavior. Hey, I'm expecting more behavioral change than you're giving right now. And some of that means that, like in healthy relationships, we have to push sometimes too for behavioral change. We can't always stay in this acceptance place. And then you're going to use lots and lots and lots of validation, right? And thinking about the 5 levels of validation, some of validation just present. You're here in the moment with the client, right? Which means though we have to also cognitively be there. And that means managing some of our own anxieties that come up as we're treating these kids, or like thinking about our session 3 hours from now, right? We have to use our own mindfulness skills to stay present. And that's validating to the client. Reflecting, right? Reflecting what they say, kind of in their own words, giving their own words back to them. In motivational interviewing, I like the analogy that they say, like, you collect flowers for the bouquet, right? And you hand the bouquet back to the client. So you collect the things, the patterns that they're talking about, the things, the meaningful things that they say, and then when you reflect it back to them, that can feel very validating. Sometimes we have to take a guess or make a hypothesis. I'm wondering if this behavior is showing up because of this experience that you have, or if you're trying to meet this goal. And sometimes we're wrong, and that's okay, right? We have to be willing to take the risk of being wrong to throw a guess out there. That biosocial understanding that we just covered, right? Of understanding the sensitivity and the reactivity and sort of the emotional burn victim conceptualization of giving that to our clients can also be very validating too, because they often live painful lives and people aren't recognizing the pain that they're living with. And then normalization, that almost all of their behavior makes sense given the environment that they grew up in, right? Given the trauma that they've been exposed to. That behavior is not always effective in the present moment, but it makes sense that it has developed. So some normalization there. This kind of gets to your question too, Joelle, but patience and flexibility. Patience and flexibility, I think, are the key for building relationship and co-regulation for these kids. But I think, again, we have to be careful of fragilization, right? Sometimes we're like, oh, I'm treating this, client with, careful gloves. And so then we don't push them into the behavioral change that they really need. And so it is this dialect of acceptance and change. When we're thinking about working with these kids, we're not like, oh, okay, I'm going to meet all of your needs because you've been through so much. That's not helping them build the independence that they need to also use the skills on their own. And then I try to put this in all of my presentations, but we have to do our own work too, right? We have to work on our own psychological flexibility. We have to deal with our own patterns of ways of behaving, how we show up in crises, how we show up when we're anxious, and making sure that we're spending time and have time to be able to process some of our own behaviors and recognize what's effective and what's ineffective too. Okay. How am I doing on time? Oof, okay. All right. So again, most often you will move enhancing safety up when you get started with TF-CBT. You will almost always start here. You may also weave in other interventions like motivational interviewing, like harm reduction, right? If you have a client who's, chronically using opiates, you may have to spend some time in harm reduction and substance abuse stuff before you can jump in to some of the trauma work. If I had more time, I'd love to talk more about harm reduction, but so we might come back to it if we have some more time, but really thinking about what are those behaviors that might have high likelihood to lead to serious injury, illness, or death of your client. I irreverently but accurately say dead clients are not clients we can help. And so we got to manage some of these harmful behaviors that have a high likelihood of leading to serious injury or death before we jump into some of our other treatment modalities. And then obviously suicide and risk monitoring. And because I'm DBT trained, I love the use of diary cards. There's a lot of free diary cards online that you can use. And the idea is that the client tracks urges and behaviors in multiple areas that can lead to risk or harm, so that they're coming in with a view of their week so that you can kind of manage the priority of behaviors. Also got tired of trees, so you'll see more different pictures in these slides. Okay, for psychoed, so jump once you feel like there's enough stability there, right? You've done some of the harm reduction work. You might not get pristine risk reduction, right? Because these kids still need skills, they still need processing to be able to get some of their dysregulated behaviors under control. So you can't stay in enhancing safety forever, but you want to get a sense of okay, I feel good enough to jump into some of the prac skills here. For psychoed for complex trauma, just logistically, you're going to need more sessions, because oftentimes you have to talk about dynamics of multiple different traumatic events and the intersectionality of those traumatic events, right? So thinking about physical abuse and neglect, right? You may have to talk about both of those things. You might have to think about sexual abuse of a family member and then the ongoing sexual exploitation and trafficking that the youth may be experiencing, right? And so you have to cover multiple different trauma types and dynamics oftentimes with these kids. And then what I have found, and this comes from the adult trauma treatment world, like cognitive processing therapy, is really starting to talk about themes. And so some of your themes are like self, others, in the world, right? Like how does trauma shape how kids view themselves, other people in the world? But also some of these themes like safety. What is their view of safety? Where did that story come from? How did they learn about safety early on? Trust, right? Power and control, right? How much power they feel they have over their lives, and if they're wielding power and control over other people, but also how people have done that to them, right? How people have wielded power and control and sometimes coercive control over them. Talking about identity and esteem and some of the self-hate stuff that might come up, and then relationships and intimacy too. And I like to introduce this early on in psychoed in your TF-CBT for complex trauma so that you can also go back to it once you're at trauma processing. And this is what we call the forests of trauma processing. So the trees are the contextual memories, the forests are pulling back and looking at some of the overarching dynamics and thought processes that have changed because of the traumatic events. Okay, when you're thinking about your second P, your parenting, right? Like don't rule out parents too soon because of complex trauma. Oftentimes we see kids with complex trauma and we see the dysfunctional parenting and we're like, nope, they're a red light parent, right? They are not green light. They're never going to get to green light. But sometimes we need to include them anyways, right? These parents likely need more support. My clinical experience is that these caregivers often sometimes have complex trauma of their own as well. And so, oh yeah, I'm seeing the nods for you all too. So they may need more support. They may need some extended collateral sessions, like their own therapy, but also like at least in Northern California, good luck getting effective adult trauma treatment around this community, right? And so sometimes you end up being some of the support, or some of your colleagues end up being some of the extended support for this collateral. And also parents just might need some after hours coaching. And I think same for clients as well, of thinking about, for a lot of our typical TF-CBT cases, 1 hour of therapy is enough, and they can use all of their protective factors, then use the skills and then come back the next week. But for some of our complex trauma kids, they need more additional outside of therapy support. And so thinking about that and billing for that, and like, some of the legality around that too. Sometimes there is no safe caregiver, right? Don't rule out parents too soon, but sometimes it's just clear that there is no safe caregiver. And so that's when we don't underestimate our relationship as a meaningful person in this client's life. And then when you're thinking about parenting and thinking about behavioral change, using this idea of like a functional behavioral analysis or a chain analysis, sort of get both people's perspective and then kind of see where things went wrong or went haywire, right? So that it can help the parent with perspective taking for the child and the child perspective taking for the parent. And I'm saying parent here, but obviously I mean caregiver. It might be a resource family. It might be an adoptive caregiver. It might be a family member that is caregiving for this kid. So I put here just some of the common parenting topics that I like to cover. Again, obviously some basic parenting strategies, and especially because if there's a lot of, trauma and chaos in the kid's early life, sometimes they just didn't learn some of the consistency and predictability that, we need in early childhood to be able to build a frame for how we behave in the world. And so sometimes we have to go back and do some of that basic stuff. I'm talking with parents about their own harm reduction and how to manage at-risk behaviors and where to have flexibility and where to have more control. This balance of like independence versus dependence, right? And so oftentimes if complex trauma kids have been caring for themselves for a long period of time, I see this a lot in a lot of resource in foster homes, right? We're like, this kid has been caring for themselves and their siblings for most of their lives, if not all of their lives. And then they're expected to come into this home and just be a kid. And that's really difficult for them, right? And so balancing this independence versus dependence, that they might need more independence than most typical children their chronological age because of the way that they grew up. Talking about the balance between validation and limit setting, how to monitor online presence, just because so much risk behavior now happens online. And this is really tricky because oftentimes parents and caregivers, we didn't grow up with that kind of risk. And so it's really hard for parents to navigate the online presence and the social media and all of that. And then also making sure that we're teaching caregivers how to take care of themselves, how to recognize their own vicarious trauma. Again, it might be their own PTSD as well, but if they do have secondary traumatic stress from what their child has experienced, and really caregiving for themselves as well. One of the helpful questions that I like to ask caregivers is, what lessons from your parents do you want to hold on to? And what do you want to let go of? What cycle do you want to stop with yourself? And what do you want to pass on to your children that you received? And that can be a helpful question to also kind of tap into parenting values, which I always like to start with parenting values before you jump into behavioral management strategies, because then you can it's some of that precision like decision, right? Where it's like choosing behavioral management strategies that highly align with their values, can be helpful in them implementing things outside of the therapeutic session. Okay. Our goal will be to get through the rest of prac, and then we'll take a short little stretch break and then jump into trauma narration. So for relaxation, you're going to do your typical things, right? You're going to do your typical relaxation strategies, both internal and external. You're going to do your typical trauma triggers and helping clients recognize what their trauma triggers are, but you may need to supplement some of those relaxation strategies with more like distress tolerance, right? So distress tolerance meaning you got to get through this situation without making things worse, right? A lot of this is like crisis survival skills. How do you deal with the emotional crisis that you're in without making your life worse, without getting you away from your own values? And this is where I will implement a lot of the DBT skills here, like changing your body temperature, intense exercise, some of the paced breathing, but distraction and acceptance and those type of things can be helpful as well. Grounding, you'll often need to implement some type of grounding for potential dissociation. You may need this grounding once you get to trauma processing too. Some of my favorite things are like name 5, which is like, what is the room that you're in? Look for 5 green things in the room, look for 5 blue things. But also like speak truths out loud. So I am Brandi. I am here in my home office right now. I am speaking on Zoom. Here in a presentation, right? Like speaking the truths out loud can be a really simple grounding exercise. Unharmful physical sensations. So that might be like ice on the vagal nerve, right? Or some type of pressure throughout, like, again, some progressive muscle relaxation that does have some physical sensations but are not harmful. And then sensory mindfulness as well. So thinking about self-soothe and using our senses to help us cope. If you are going to teach mindfulness, which I highly recommend you do, really start with the present moment and participatory mindfulness. So instead of closing your eyes and doing something internal, right? Thinking about how do you just brush your teeth when you're brushing your teeth? Or how do you just clean when you're cleaning? Or how do you, like pay attention to the road when you're driving versus some of the internal things? Because for trauma survivors, right, closing your eyes and going internal, if you don't have the skills to be able to manage it, can be more harmful than helpful. For all of these practice skills, you're also teaching your client about workability. And so for those of you who are trained in ACT, you'll recognize some of this language, right? It's like what works in the moment? What gets you closer to behaviors that's congruent with your values? What gets you closer to the life that you want? And it might not be all of the things that we're teaching, but it has to be something, right? And so finding something workable that helps you sort of relax in the moment, even if that's just bringing your baseline down just a bit. So again, the other addition to relaxation is you're going to be talking about managing tension reduction behaviors. And when you're talking about tension reduction, it's always validation first. So this behavior has served a purpose. There are some pros to harmful behavior. It has been reinforced somehow, right? So you want to validate the purpose, right? You want to honor that purpose, but not necessarily the method. You can discuss long-term consequences of tension reduction behaviors, right? Like how is using substances to avoid these painful emotions, how is that going to affect the life that you want? And then connecting the tension reduction behaviors to trauma triggers or the trauma experiences. And those are your bursts of exposure. I often will teach urge surfing. So how do you like let an urge rise and kind of surf around it? And then it will eventually decline and then it's going to come back up, right? Because that's how sort of urges go. And you may need to go back to some harm reduction techniques here as you're talking about managing tension reduction behaviors. And then you're going to do your typical trauma trigger identification, right? So helping kids and youth, young adults, like think about what are the people, places, and things that trigger shame or trigger discomfort or trigger pain, right? What are the sensory experiences, the sights, the sounds, the taste, the smells? What are the emotions? So oftentimes, like when just a very typical emotion arises, like sadness, right? That can then easily lead to shame because the first time they felt sadness was when that sexual abuse started, right? And so you can see how all of the emotions get really tied together. And then, as we mentioned, connection, love, and belongingness may also be triggering. And youth maybe feel triggered by the therapeutic relationship or other acts of care or concern. I sort of on repeat say, I'm doing this because I care about you and not because I want something. And then maybe throw in some truths like, well, I do want something. I want you to use skills, but I want you to use skills to benefit your life, right? You using skills versus not using skills doesn't change my relationship with you, but I do want you to have a better life. And that's part of my role in your life is to have a better life. Okay, affect modulation. So if you remember from typical TF-CBT, this is somewhere between 3 to 5 sessions. I would say that probably doubles when you're thinking about complex trauma. You may spend a lot of time in affect modulation, and that's because of the long-term avoidance of any sort of emotional experiences at all. Often these kids are, very, very numb. They've just numbed out their entire emotional system. And so you may have to do some other emotional exposure activities that you might not have to do for your typical TF-CBT cases, right? But we're teaching them emotions are useful information. They tell us something. And our emotions depend on the context and the different strengths and that they're multi-layered and they often trigger each other and kind of teaching them about the emotional system as a whole. That negative states are temporary and they can be tolerated, right? Like you can tolerate sadness, you can tolerate pain, you can tolerate some shame, and helping build that tolerance with skills. Really talking to them about communicating about emotions, just talking about them can alleviate some intensity. I often say, what is the antidote to shame? The antidote to shame is connection. And so if you're feeling shame, talk about the thing that makes you feel shame. And then that just alleviates some of the shame without using any other skills. And then remind them again that that problematic behavior, that behavior that you're working on the behavioral change with, was usually emotional modulation in a survival situation. You use substances to regulate your emotions because of the experiences that you've had, or cutting or problematic relationships or whatever the problematic behavior is. The attunement and co-regulation that you've already started building is crucial here, right? So like oftentimes you are the main model of appropriate, effective emotions. But that means, again, we have to show up with radical genuineness. We can't be the robots that are like, okay, now I'm going to do this and let's do this worksheet, right? We have to show up as our full human selves to be able to role model what it is like to experience a range of emotions and be able to cope with those emotions. You may also include some more radical acceptance of painful emotions, right? Like it's pain plus rejection of the pain that equals suffering. Pain is just a common part of the human experience. Like we cannot get rid of it. We try real hard in lots of different ways to get rid of pain, but it's just part of being a human being. And so when we can open ourselves up to that pain, then we reduce our suffering. You're going to be practicing labeling in session. You're going to do, again, a lot of that guessing. I'm guessing what you're feeling, even underneath some of the numbness, and then connecting their affect to their trauma-related triggers. This is also an integration of DBT here too. So I like to use the skill opposite action. And so thinking about what is the primary emotion, what is our action urge? And action urges are very individualized. So even though I put some of the common ones here, you really have to ask your client, what does your brain and your body want to do when you are feeling fear and anxiety? And getting a sense of behaviorally what that action looks like. And then the skill is doing the opposite of that, right? And so if your action urge is to avoid, flight, or retreat, the opposite is to approach, face the fear, and repeat facing the fear. You know, if your action or urge for shame and guilt, even if it's justified, right? Again, shame, we often think about shame as this only this negative emotion, but shame is useful. It gives us information about what behaviors we need to have to be in community, right? And humans need to be in community. And so sometimes we do things that do affect our community, and that shame is justified. And sometimes, or most of the time, our action urges are to avoid that shame, to make excuses, to blame others, right? So the opposite is to repair, to apologize, to commit to behavioral change. But if the shame is unjustified, right? So like thinking, oh, it's my shame that because I was sexually abused, when that's not your shame, that's the perpetrator's shame, right? Our action urge is to avoid or punish ourselves. And so the opposite is to approach, right? The memories, provide ourselves self-care, give us ourselves validation, and connect in healthier ways. Okay, just a couple more slides. We'll take a stretch break. So cognitive coping. Really complex trauma is deeply ingrained survival thinking. And so your client may not leave treatment with all of this healthy, balanced thinking patterns, right? Because oftentimes they've had these survival thinking patterns for so long. But your goal is to start to understand where that survival thinking came from and then be able to question it, right? To have some curiosity about that survival thinking, because the survival thinking over time can occur in non-survival situations. So you don't need your guard totally up in this therapeutic session, right? Even if you need it at school, even if you need it at home. You know, and it can result in situations or actions that don't fit what the, you know, problem is. And then it often elicits this negative interaction with others, which then you can see as this vicious cycle of like, I'm scared to connect, you know, and then I use my survival thinkings and then people don't connect. And then I have this self-fulfilling prophecy of nobody loves me, nobody wants to connect to me. And you can see how that cycle gets really enhanced over time. So I just put a couple steps here to think about the cognitive triangle and survival thinking. And one of the key pieces here is just identifying and recognizing that thoughts are not facts. That thoughts are things we need to explore, that we need to be curious about. We need to try to understand what our mind is trying to tell us without relying on our mind is telling us facts. I sort of silly playfulness say like this is like the pink elephant skill. Like you can say, oh, I'm a pink elephant, and it does not make you a pink elephant. But you can say it over and over and over again, but it doesn't match the facts. And I love this because then it's like you can just be like, oh, I think pink elephant is going on here, and then they can sort of recognize that they're treating their thoughts as facts. Again, you want to validate the survival thinking. So where is the survival thinking coming up in non-survival situations, but validate that this survival thinking helped them survive in this situation. It's just it's not needed in this non-survival situation. And then you can start to sort of gently challenge some of the survival thinking in non-survival situations. But often I will supplement the triangle with like a more functional behavior analysis or chain analysis where you're thinking about all of the vulnerability factors and the thoughts and the feelings, including the thoughts and the feelings and behaviors, but also the pros and the cons of that behavior and how that behavior gets them closer to what they want versus farther away. And here are all the core beliefs, and these are not all of them, but there are many of them that sort of show up for these clients, right? That they're unlovable, that they're incapable, but there's something wrong with them, there's something defective with them, that they're going to be abandoned, right? Sometimes this looks like self-sacrifice. I see this a lot with my exploited and trafficked youth, right? Where it's like, I have to give and give and give and give, and I don't deserve anything in return. And so I'm giving of myself in such a way that's ineffective and I'm self-sacrificing for others. Sometimes this looks like helplessness, or sometimes DBT calls it active passivity. I'm just sitting on my hands and not doing anything to change my life. And then sometimes this can look entitled, right? I deserve this and I deserve this right now. And that can be really harmful to long term. And this is where we see some of our complex trauma kids that are wielding power and control over other people to manage their feeling of powerlessness inside. Okay, actually, let's take a little stretch break and then we'll come back. Maybe just 5 minutes if that's good. Hopefully you can stand up, stretch your body a little bit. If you have a window, look outside of it, and then we'll be back in 5 minutes and we'll jump into narration soon. I'm just looking at content, and I think we are going to have time to consult on some cases. So if you have some cases in mind and are willing to sort of share, I'm happy to provide some clinical consultation advice as well. We'll definitely have some time for it. Okay. So last piece of cognitive coping is just to remember you can kind of start some of that Socratic questioning, maybe with non-trauma related beliefs, but really asking things like, how old is that story? Who were your teachers? So going back to self-hate, right? I like to talk about who were your teachers of someone, who were your early teachers of this, and are they reliable? And are that your teachers that you want to emulate, right? I'll ask the question of like, what do you think makes an effective teacher? And usually clients say things like patience or non-judgmentalness or kindness, and then sort of asking, were those the qualities that the teacher of your self-hate had? And if not, right, you're holding so tightly to that message, but you don't really respect the teacher and you don't want to emulate the teacher. And so kind of thinking about narratives that have just been built over time from others. How does that thought serve you? How does it harm you? Is there a kernel of truth in it that is helpful? What does the thought tell you about you and your values? And does your thought include all of the information? I remember Socratic questioning should always be done in this sort of curious light, right? So it's like, let's think about our thoughts, right? Some of those metacognitions and thinking about what serves us and what doesn't serve us and what we're holding on to, what we might need to let go of. Okay. All right, so I would say for prac, again, you're going to be spending a longer period of time in prac than you are with your typical TF-CBT kids, but you still have the goal of getting to process some of their contextual memories and their thoughts and feelings about their memories in order to sort of unpair those intense thoughts and reminders with overwhelming emotions, right? We want to be able to desensitize them to the memories so that they're not having this big reaction that then they're needing to avoid that then causes the hyperarousal symptoms and some of the dysregulation. Our goal is also to uncover and process any unhelpful or inaccurate thoughts. Oftentimes, this is things around blame or identity. It's because of who I am that I experienced some of the things that I've experienced. And again, our ultimate goal is to help them process and synthesize these traumatic experiences to move forward in like a balanced or healthy way. So thinking about this is just something that happened to me. This was part of my experiences. This is not who I am as a person. right? And these are my values, and I can kind of stand strong in my values as I move forward with life. Okay, I put a broken window here because oftentimes we talk about this dance and trauma narration as a window. And so you're going to be pushing up against the window, trying not to break the window, right? But you got to put a little bit of pressure, a little bit of stress on that window in order to create the change. But sometimes you break the window, right? And so the good news is I always say I'm in the window repair business when it comes to emotions. So you can come back in, we can repair this, we can get back to trauma narration as soon as possible. And then I know a little bit more about your capacity and your limits and what pushes you too far. But it's my job to push, but I don't want to push too far that then your regulation, right, gets broken. But the other thing for complex trauma is you cannot wait for perfect regulation. Like you're just not going to feel so great about going into trauma narration. It's not going to be that warm and fuzzy feeling where like this client is 100% ready. And sometimes we have to start it anyways. And thinking about, is that client safe enough in your office and in this relationship to be able to process some of the memories that they have? And reminders to ourselves that trauma narration improves regulation, right? Like if you think about our conceptualization is the core is the trauma that's pushing them towards dysregulation. We're never going to get rid of the dysregulation without dealing with the trauma and the trauma memories. But different than other clients, we may need to kind of go low and slow, and you may have to weave in and out of trauma narration, right? So sometimes you're in trauma narration and then a risk behavior happens and you have to move out into enhancing safety, get the risk under control, and then move back into trauma narration. And this slide is just basically giving you permission to be able to do that, right? That is still congruent with the goals of TF-CBT. You want to give appropriate control, avoid power struggles, and then just sort of carefully attend to what their capacity is. And again, it's just this is part of the humanity in us, right? Is that sometimes we just push a little hard. But I have found that it's especially as people are starting TF-CBT, they're not pushing enough and kind of fragilizing their clients versus pushing too hard and then having to repair broken windows. So remember, there's two sort of, not competing, but there's just two sides of goals of the trauma narration. Some of it is desensitization to the contextual memories, right? So it's talking about the memories, repeating the memories so they have the emotional exposure to it. But the other piece is making meaning and processing and kind of showing up, like talking about how this trauma has showed up in parts of their lives. And again, what do they want to hold on to and what do they want to let go of in trauma narration? Okay, so back to my trees here, right? And so when you think about trauma narration, you're going to want to narrate about trees and you're going to want to narrate about forests. And so trees are sort of your typical TF-CBT chapters, right? This is the who, the what, the when, the where, the how. So if the tree is that sexual abuse when they're 5, you're getting all of the sort of nitty-gritty details about the sexual abuse when they're 5. And that goal, again, is desensitization in a validating safe space, right? You're bearing witness to the things that have happened to them and providing an acceptance, a fundamentally different response than what usually happens when they first tell. Right. And you may have multiple trees that you have to process. So some of that might be like in first sexual abuse experience, the day your dad left, a day in the life of exploitation and trafficking. What does sort of a typical day look like? So that's the who, what, when, where, and how. But you also want to process the forests, right? And so this is the overall effect of the trauma. This is how have all of these things, right? All of this chronic trauma, how has it affected your view of yourself, of other people, of the world? This is kind of the why, right? And again, this is where you can pull your themes back up. What has my trauma taught me about safety and trust and power and control and love and belonging and connection and all of those like meaningful themes in our lives? How did I hold on to my values even in the midst of trauma? have one example that's just kind of popped into my mind. I was working with a youth. She was actually incarcerated in the youth detention facility. She had had a long history of exploitation and trafficking. And she was there. I can't remember what crime she committed while she was on the run, but she basically left her residential placement to go back to meet up with the trafficker, right? This young girl had followed her. It was a kid who was younger than her. Obviously, she's in a residential placement at risk for sexual exploitation and trafficking. And the client I was working with was basically mean to her and told her, no, you can't go with me. You have to go back. Walked her back to the placement before she left care. Do you see how, like, if we only focused on the problematic behavior and not the values within that, right? She could have easily taken that younger kid with her. The trafficker would have met up with her, right? The trafficker probably would have trafficked her because that's what traffickers do, right? But this kid stayed true to her own values of I'm not gonna bring other people in to this life, even though I'm making the choice, right? For myself. I'm not introducing someone else to that. And so these are kind of the stories that help kids get connected to their values, even when they didn't want to, like even when, some problematic behavior was happening or some trauma was happening. Another client thinking about values too is because of the early sexual abuse in their family and really in their whole neighborhood, a lot of the kids had problematic sexual behaviors with each other, which really confused my kid who's almost an adult now. Um, and she was like, no, I don't want to do this, right? She used her voice. No, she ended up being forced and coerced to do it anyways. But we talked about, like, one of our forest chapters was about processing this, trying to use your voice and listening to your voice and using your voice. And it didn't work because of the power and coercion that other people had, right? But like still the bravery to be able to use your voice and to like tap into your own moral compass of like, I know this isn't right. This doesn't feel like a right thing to do, even though she was 7, 8, 9 years old, right? That is an example of a forest chapter. And so thinking about how do we process the making meaning in of these different things. And this is also where you're going to use your cognitive processing techniques. And so sort of pulling out some of the more maladaptive thoughts and diving in deeper to those as well. Okay, the other intervention that I love, and I usually honestly start here. I was having trouble sort of ordering the slides and how I liked them best, but I actually honestly always start with a trauma timeline for complex trauma. So this is a slightly adjusted timeline for confidentiality. The client that I really worked with, he was a 17-year-old, 16-year-old male who he was also incarcerated in the youth detention facility. He unfortunately had gotten connected to like some gang violence pretty early on and had ended up engaging in a lot of violence through that, which led to his arrest. So we just started with the black line with hashtags, right? So each year of his life was a hashtag. And what this looked like in session is I just started saying, okay, let's start thinking about contextual memories first, like where you lived or what school that you went to. And then we put that on the timeline. And then we started like, okay, now let's put some of your traumas on the timeline. And if I'm starting with this, I'm telling clients, I'm not going to ask you about a lot of the nitty-gritty details yet, right? Today, I'm not going to ask you about that, but I just want to get a sense of all of the things that you've experienced that has shaped you, both positive and distressing and uncomfortable, and putting it on this timeline. And so some kids like to start like from where they are now and going backwards, and sometimes kids like to start at their first memory and go forward, and either of that is fine. He started from 0. He had heard from his grandmother and other family members that his mom and dad fought a lot right after he was born. And so he didn't have any contextual memories of this, right? But he knew that he had been exposed to DV from 0 to 4. At 4, his dad left. And right before his dad left, the dad was engaging in a lot of physical abuse towards my client. Around age 7, his mom started using, right? That's when the sexual abuse started. I believe he was sexually abused by an older cousin. The kids got removed from mom's care for a while in foster care, and then they were reunified. And then by 13 was his first stint in juvenile hall. He'd gotten released and gone to a residential treatment facility, and then got arrested again. We also put the pink is helpers in his life, which was very meaningful to me that I got to be put on the helper list, but also a probation officer, Miss Webb, that he really loved and connected with, a second grade teacher that he remembers treating him so kindly. And then at 5, his sister was born. He has a really strong connection with his sister. Um, these are some of the positive memories. He's talked about the positive memories of starting school and getting like the first sort of consistency and structure in his life when he started school. He remembers a birthday party, I think it was at Chuck E. Cheese, if I'm remembering right. And then the green here is behaviors that he didn't know were trauma-related behaviors when they started. But at 7, he started throwing temper tantrums. But look at that meaning, right? That was right after the sexual abuse started. At 9, he started having problematic sexual behaviors. And before he was 12, he started avoiding anxiety and depression by smoking weed. And then you can kind of see the pattern from there. And so if you look up at the top of the timeline, right, here are our forests. So we took our forests, and he put forests in different colors. He put relationships and trust. And then we went and circled everything on his timeline that affected his view of relationships and trust, both positive and negative, right? So when his mom started using that, affected their relationship, but so did that second grade teacher that showed kindness to him. Um, all of the orange are things that affected his identity, his view of himself, right? And you can see the safety. And these are the 3 primary forests that came up for him. And for your clients, it might be something different. But you can start to see like, okay, now we can see some tree chapters that we're going to have to write, but we also see some forest chapters that we could write about. And so I love to use this to kind of get started. Sometimes this takes a few sessions. That's okay. It's all trauma work, right? This is all trauma work. And then you can kind of think, okay, now looking at this timeline, what are the things that are bothering you the most now? What are the things you're re-experiencing, you're dreaming about, you're triggered about? And let's choose those as tree chapters, right? So that's when we're going to write the who, what, when, and where. We don't have to write the who, what, when, and where and how for all of these things, but let's take the things that are sort of bothering you the most from like a memory perspective. And then we wrote some chapters about some of the forests as well. Questions about this timeline or helpfulness you think that it might be for some of your clients? Joelle, do I have this whole trauma timeline developed as a training tool? That's a great question. I actually do a full day training on trauma narration and cognitive processing. And we really practice timelines and go like deeper into like what would some of the tree and forest chapters look like. But it's 10:32, so I don't think we'll have time to do some of that today. But good question. Other thoughts, reflections?
I just love how this is so reflective and really challenges not just the client, but yourself as the therapist to
Yeah.
have a really unique perspective on joining the client in their life story,
Yeah. Yeah.
it's really great.
Thanks, Joel. I appreciate the feedback. I think for me too, it can be so validating too, even in like, holy shit, I've been through a lot. Because a lot of times our complex trauma kids minimize their experiences. And then when it's down on paper, they're like, oh yeah, well, I guess that makes sense. One like very sad but like meaningful thing that a different client was working on her timeline. Oh man, I should probably put hers as a slide too, because there's just like so many things. But she said, I don't really remember everything before 5 is blank. I wonder what happened to me that I don't remember. And even though that's like so painful and sad, right? Like she was living with that alone. She was living with this, this fear of what happened to me when I was younger. alone. And so like, remember, antidote to shame is connection. And so being able to say that out loud and connect and get validation around that, like that is really hard. That is really painful to know that your body may have experienced things that your mind doesn't remember. At the same time, like your brain was also protecting you from some of that stuff too. But you can see again how that self-hate started really early, maybe even before you could talk, and helping her understand her behavioral pattern, that she doesn't hate herself because she's unlovable. She hates herself because she was taught that from inappropriate teachers early on. And then, like, selfishly as a therapist, this is so organizing, right? Like, it just organizes your own thoughts and your own like journey of like where to go and where, you know, like what you can leave behind. And like for me, it releases some of that, you know, anxiousness about what is the journey, because now you can see the journey on paper, and then you can collaboratively decide with your client about what's next. Okay, so you're going to wrap up your cognitive processing, right? After you do your tree chapters, your forest chapter. This is kind of like your last forest chapter, your making meaning chapter. I like to call this sort of the bow on the trauma work, is you want to get responses to some of those reflective questions. Why did you do this? For some clients, it's like, why did I make you do this? How did this trauma work help you? How does it help you now? How does it help you in the long run? What are those resiliency factors, those values that you've noticed in yourself as you told your story? What's next? What's next on your healing journey? What takes place next to get the life that you want? How might you use these experiences to help others, right? Many of our clients highly value contribution. And so thinking about how do you use this lived experience to contribute to others? What lessons from your trauma do you want to hold on to and let go of? And I do want to put a caveat here, like this is not toxic positivity. This is not like, oh, I'm so glad I experienced all of this trauma because now I'm XYZ. No, but we do learn from our painful experiences. We do grow from our painful experiences, and recognizing that is a meaningful part of some of our healing journeys too. Okay, so you will be in trauma narration for longer than typical, but you don't want to stay in the past forever, right? You want them help them move through the past and get to some present-oriented stuff. You may still have to implement in vivo exposure. So remember, this is for kids who still have some of those external trauma triggers, or they're avoiding things that they really need to approach in their life. You are still preparing conjoint sessions if appropriate. The other thing I like about the timeline is caregivers can also have kind of their own timeline and see how sort of memories match and memories differ, and validating sometimes that memories differ. Oftentimes I've had caregivers be like, I had no idea they remembered that DV when they were 3. And you're like, yep, they do. They do. They have very clear memories of some of this that has happened. And again, kind of weaving in the parents' helpfulness or ineffectiveness and effectiveness is showing up as a caregiver. And oftentimes, if the resource family is safe enough, they often don't get this history, right? CPS doesn't give you like, oh, here's all of the things that your kid has been through, but the kid feels like the resource family is trusting enough to be able to hear some of their history. That can be really helpful in sort of explaining some of the behavioral patterns that come up. You're going to return to enhancing safety as you're wrapping up. And so this is where, again, hopefully some of those risk behaviors to have decreased or at least gotten to a more manageable level, where you might talk about healthy relationships, sexual decision-making, ongoing values and identity work. And then just, right, we might not achieve ideal symptom reduction. Get your post measures anyways, but these are the kids whose, CAT scores are a 50 and maybe they go down to a 30 and 15 is clinically significant, right? So they're not underneath the clinically significant range, but they still have received some symptom reduction. And they're, you're really looking for some of those things that our measures don't really get at. Like, are they connecting to people in their lives? Are they taking healthier risks related to some of like trust and safety? Are they utilizing skills when they're experiencing symptoms, and looking at some of that for your qualitative data as well? Okay, a couple closing thoughts, and then we can answer some case questions. Don't forget to take care of our own emotional being, really at and after work. I think even though like self-care and vicarious trauma and compassion fatigue is now part of like clearly a part of our literature, oftentimes it talks about doing things outside of work. So like your bubble baths and your, vacations and things like that. Still do that. I think those are really helpful to sort of reset us. But we also have to figure out like how do we manage our uncomfortable emotions at work? And when you're thinking about this, I love Brian Miller's CSERT work, is he talks about what brings you emotional labor and what brings you emotional energy. And sometimes compassion fatigue is a misnomer because, like, think about those times when you've showed up to a trauma session and your client has just given the hardest memories of their lives, and you're there and you're sad, right? But you're there, you're present, you're leading with compassion. That's actually not the stuff that fatigues us. That actually usually brings us a lot of emotional energy. If you think about, I'll speak for myself, the things that bring me emotional labor is systemic barriers, documentation, right? And those type of things. But oftentimes we only focus on what brings us emotional labor. So it's also bringing some mindfulness and present moment awareness to what brings us emotional energy and what sustains our career. I supervise a lot of incoming interns who are sort of just first starting the work. So, like they're bright-eyed and bushy-tailed coming in. I have them write a compassion satisfaction letter to their burnt out self. So what are you going to say to yourself when you're burnt out and you're crispy and you're feeling like you just can't manage, right? You can't manage the work anymore. Remind yourself of your purpose, remind yourself of your values, remind yourself to take care of yourself, that you're a human being too. Um, as mentioned, this might be long-term work in TF-CBT. It's okay that it's longer than your typical cases, but you don't want to stay in trauma work forever. Don't go it alone. We're a communal species and we need our communities. So connect, right? Connect through the pain, the sadness, some of the helplessness, especially when it comes to the systemic barriers and all of the things that bring us so much emotional labor, like just connecting through it and sharing our experiences with others. And then just constantly check in with our own values, right? So over the years, sort of my primary values have been connection, contribution, and curiosity. It's just lucky that they all start with C's, right? But sort of like checking in with that. So like, what can my curiosity tell me about this situation that I'm experiencing pain, or this caregiver just yelled at me, or I'm not sure what to do with this client? How am I still contributing even when the work gets hard, but contributing to others and also contributing to myself, because sometimes we forget about how our values apply to ourselves as well. Okay, so I think we have about 15 minutes here. I'm gonna stop sharing. I'll tag my email in the chat so that you all have it. But any thoughts, questions, reflections, or any cases that you might want to talk about that this might be a helpful approach for? Anybody want to share about a client that they might be working with and some of their dysregulation patterns? No, no questions? Okay. Sadie, are they able to provide feedback in any way, or is there an evaluation for them to fill out?
Yeah, I have an evaluation I'm actually going to drop in the chat. It's very quick if you can just spend 2 minutes on taking it.
And then I'll stick around too in case anyone else has any questions. But happy to be a contact or a resource for you. Oh, I was going to put in those that self-hate book. I'll do that really quick too, and the implementation manual. So I'll do that while y'all are filling out.
Thank you, Brandi.
Yes. that just a thank you? It was just thank you.
Yeah, thank you guys for coming. And yeah, Dr. Brandi Liles is here for a few more minutes if anyone has any last minute questions.